syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Hi, everyone. Welcome. Welcome to the April 25th, 2026 edition of TMD Demystified. I am Tony Urbanic. This is a live stream designed for both patients and doctors who want to have the opportunity to get information, ask questions, make comments. Even those who would like to criticize what I have to say are welcome to this site, which is broadcast today from beautiful Franklin, Tennessee. It's a beautiful day outside, and I had a wonderful morning doing some yard work, mulching throughout the yard, and actually had a little fight with one of my rose bushes. I don't know if you can see that or not. The rose bush won. But today I'm going to start by talking about one of the patients that I had last week while we wait and see if there are any viewers who would like to ask questions. The platform is designed simply to have both patients and doctors, primarily dentists, I think, who are interested in the topic of TMD or who are our current doctors who are network providers who provide the service that we call the Urbanic Device and Protocol, which is highly successful and proven to be statistically successful with an independent university study, patented device and protocol, FDA cleared, that we use here in Middle Tennessee in our practice, and also doctors who are licensed to use it, a growing number of doctors throughout the United States in about 20 states now. But the purpose of the live stream is to give a little more information and the opportunity for doctors and patients to ask questions about this devastating disease. And the patient that I had last week, I actually had two patients. One I'm going to discuss, but they were both kind of simultaneous on the same day. One was a 23-year-old female, and the other was an older 53-year-old female. They both had a similar response to the consultation, which I'll discuss in a minute. But I'm only going to discuss the record of one of these patients. Obviously, I will not give her name, but I can use her first name, which is Kim. And Kim came in to see me with her chief complaint is I can't open my mouth. And I'm going to give you a little bit of her history, read it out, and see for those who might have the similar circumstances or a patient who has some of her symptoms, or a doctor who sees this kind of thing and believes it's a lost cause, that there's nothing you can do about this, that you refer to it as TMJ. Everyone in the world calls it TMJ, temporomandibular joint. Everybody has two TMJs. It makes no sense to me, never did. But to this very day, in 2026, the majority of patients, and especially doctors and physicians, call it TMJ. Frankly, everybody's got two TMJs. Proper terminology is temporomandibular joint disorder. It's only a single disorder. There are those who want to make it complicated. They want to make multiple disorders out of it because they don't understand the cause. But I've talked on that quite often. And if those of you who want to take a deep dive into all these specifics, I welcome you to watch some of the episodes of TMD Demystified on YouTube. Is a podcast that I do every Tuesday that is recorded. It is not a live stream where you can comment or ask questions. But I cover all the aspects of TMD Demystified and what I discovered about this problem, which actually was very, very simple when I did my own independent research and got rid of all my biases, surgical biases, because I'm an oral and maxillofacial surgeon who did surgery on these joints for my first 36 years of my 50-year career as a facial, maxillofacial reconstructive surgeon. 2,000 temporomandibular joint cases. And after 36 years, I finally decided that surgery was not going to be the ultimate answer. And I went off on my own research project because I had a very, very strong research background, not only independent degrees in cell biology and anatomy, plus a medical degree and a dental degree, but 2 years with the NIH in my own independent research project on facial growth and development. So I did take a look independently without any bias about like what is really going on with this disease that everyone agreed that was confusing, complicated, and nobody could figure out. So all that information is on YouTube, on the multiple episodes. I think we're up to about 249 separate episodes of TMD Demystified on YouTube. But today we're going to talk about Kim a little bit, and while we wait and see if anybody arrives and has any questions. And if not, then we'll just call it a day with discussing this one very, very interesting patient that I saw. She came in to see me, and her chief complaint was limited mouth opening, can't open my mouth. She also reported symptoms on taking a complete history of frequent and/or recurring headaches, earaches, neck pain, jaw pain, feeling a fullness in her ear, like she had water in her ear, which of course she hadn't been swimming, a history of dizziness, jaw locking, which was separate than I can't open my mouth. Locking is defined as when you go to open, feels like you get about halfway there and you can't open all the way until it springs open. And then her chief complaint of limited mouth opening. On measurement, she was only open to 15 millimeters, which is basically one finger breadth, about 15 millimeters we call interincisal distance between the incisors. She could get one finger in, and she had been that way for 7 weeks. The first issue, before we get into the rest of her history, and physical examination, is she had seen, by the time she got in to see me, throughout her history of this problem, which goes back to age 15, she had seen multiple doctors. And in the past 7 weeks, since she couldn't open her mouth, she had seen 4 doctors specifically. She saw her PCP, an ENT. I believe she went to the emergency room, and she saw her dentist, and none of them could offer any help or even hope of help for her. And that is why for 7 weeks, she had basically been on a liquid diet and couldn't open any further, which I will comment now is a very dangerous situation, because if Kim had had a motor vehicle accident or some other injury where she had to have an emergency surgery, the anesthesiologist would have a very, very difficult time if she needed to have general anesthesia, getting that tube, the endotracheal tube, down her throat because she couldn't open but 15 millimeters, which could be life-threatening, very much so. And actually, unless the anesthesiologist had all the proper equipment, there is a technology where someone can't open. It's pretty complicated technology where they thread basically a smaller tube down the nose and then take a nasal endotracheal tube and with care thread it down through there, but you have to have a special camera and you have to have special equipment. And then the only other way to save a patient's life who cannot open their mouth is a tracheostomy, at which point you better have a surgeon around who can do a emergency tracheostomy. So her situation for 7 weeks was complicated by the fact that she was in danger, but her chief complaint was, I haven't eaten anything in 7 weeks. Her history included she had a class 1 occlusion. She had attrition of her teeth, meaning she was clenching and grinding. Palpation of the coronoid process of the mandible was painful, which occurs on everyone who has TMJ disorder. If you slide your finger up the coronoid process from the inside of the mouth, it's going to hurt. I mean, 100% of people who have TMD, it's not the diagnosis, but I can tell you with authority and a lot of experience doing consultations on well over 5,000 people, that if you put a glove on and slide your finger up the ramus and touch the coronoid process, they're going to go ouch if they have TMD. And if they don't have TMD, they're not going to go ouch. And her joints were tender on the diagnostic move, which is opening widely, putting your fingers in the depression, which occurs when the condyle comes out of the fossa. When I open widely, firmly put your fingers in that depression and have them close rapidly, and they will say that they feel pain. Ouch. And she was 6 out of 10 on the left and 4 out of 10 on the right. But she could only open to 15 millimeters to begin with. But her joints themselves were tender when she went from the open 15 millimeters to the closed position, which only indicated, all that indicates is there's inflammation in the joint. And that's all you need to know, because that is the diagnosis of TMD, inflammation within the temporomandibular joint. Actually, the definition of TMD should be changed to inflammation within the temporomandibular joint, because if you look at some of the podcasts that I record, you'll see, and I can show, and our study shows without doubt, that inflammation of the joint creates each and every one of the symptoms. Each and every one of the symptoms Kim had, and every one of the symptoms that anyone has who has temporomandibular joint disorder. She had her third molars absent, and she had no history of orthodontics and no history of trauma. The radiographs, which I'm going to share with you, I believe. This is Kim's radiograph, and I can show it one of two ways, but I'll just share it with you on my computer here and see if you can see my pointer. When I looked at the radiograph, these joints, here is on your left side, this is Kim's right temporomandibular joint, and I am covering up the left joint. But both joints showed evidence of significant degenerative bone change. She had undergone and in the process of undergoing reconstructive replacement of several teeth with a couple implants, which had not been finished off and loaded yet. But the feature on this x-ray, which I took one glance at it, and I knew that this little wire suture, it's a wire suture right here, a wire ligature, meant that this patient, Kim, had prior surgery for temporomandibular joint problems, which went back into the uh, mid 80s to early 90s. I knew one look at this ligature. I knew where this surgery was done. I knew the name of the surgery. I knew who the surgeon was who did this procedure, which will go unnamed, and the hospital it was done at. But the point is that she had surgery for temporomandibular joint problems on her right side. This is her right side. And the left side, again, which is covered up by myself. Let me see if I can bring this up and show the other side. This is Kim's X-ray, and this is her left side. This is the unoperated side. The one with the suture is the operated side, but she was having pain on both. And I guess I can interject here. That's why I quit doing temporomandibular joint surgery of any kind. I am not the surgeon on this case, if that's not obvious. I knew where this surgery was done. This particular surgery is the one temporomandibular joint surgery that I never tried to do. I never wanted to do because I knew that the complication and failure rate of this surgery was pretty strong. I did know that certain types of surgery were better than others. Actually, 2/3 of my cases did very well. And to this day, patients come in with one side that I did surgery on, very effective, but they complain of now pain on the other side. So that little wire that I showed you is just an indication that she had prior surgery, but now has symptoms to the point where she can't open up. And that kind of goes to the point why I quit doing surgery 15 years ago and did the research to figure out how to treat TMD non-surgically. So I wanted to bring this patient to your attention because this 53-year-old woman and the 23-year-old woman who I saw on the same day both shared the problem of severe temporomandibular joint symptoms, frequent and/or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ear, fullness in the ear, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. The 23-year-old had only locking, and it wasn't as severe as Kim's. The 23-year-old was able to open, as I recall, to about 40 millimeters rather than what she should be able to be open would be about 55 millimeters. But what they both shared is once I completed the examination and I completed the history, and then I went through my usual discussion of exactly what causes temporomandibular joint disease. Inflammation, how inflammation is formed, how there are 3 causes to damage the joint themselves. 3 things, 3 situations damage a joint. And one of them is bruxism. The other one is acute traumatic events, the most common being motor vehicle accidents and whiplash injuries. That is the most common trauma that generates damage to the temporomandibular joint. And then functional malocclusions, which I've talked on several times. A malocclusion, a bite that is so dysfunctional that it overloads the joint. What all 3 of those things have in common is they overload the joint. When you overload a knee, it breaks down. When you overload an elbow, it breaks down. When you overload the temporomandibular joint, it breaks down. But if you unload the joint long enough with a device and protocol that unloads the joint by unloading the posterior teeth according to the protocol 24/7 for 2 months, nighttime only the rest of your life, it makes the inflammation go away. But what both Kim and the second patient, the younger patient, had in common, and most patients, every patient is quite different that I examine and take a history on, quite different. Nobody comes in identical. But these 2 patients had an identical reaction because when I finished explaining exactly how the symptoms are generated through inflammation and explained to them how the symptoms are cyclical early on, cyclical symptoms come and go, and then as time goes on, the symptoms get more frequent and they pick up symptoms. But when I went through it, and that explanation usually takes me about 10 minutes, both of them independently started to cry. I mean, the tears, crocodile tears. And I've seen this many times before. And these were a younger woman and a middle-aged woman who had been run around in circles by our establishment, our dental establishment and our medical establishment. This is why I do what I do, because it is not unusual for me to explain to a patient and give them some hope. Just give them some hope, and that they know that they're talking to someone who has the experience. And I can prove what I say. I don't blow smoke. Uh, and the experience to actually make these symptoms go away, just the hope that there is someone who knows what they're talking about. And both of these women, in their own way, there wasn't an exact thing, but they both indicated I was the first doctor who ever sat down with them and explained to them what the disease was all about. Unfortunately, the dental community, the dental profession, shirks their duty on, first of all, shirks their duty on understanding this problem. And I find that, it is very rare for a dentist, because very rare for a dentist to understand it's all about inflammation. They just want to treat symptoms. And the physicians just want to treat symptoms. They treat symptoms with drugs. The oral and maxillofacial surgeons try to treat symptoms with surgery. The physical therapists try to treat the symptoms with physical therapy. The psychologists try to talk somebody out of clenching and grinding, which is impossible to do. You can numb up somebody's face, paralyze somebody's face with Botox, botulinum toxin A. If it hurts right here every morning, you can paralyze that, and it won't hurt in that one spot, but it has no effect on the disease in total and all those other symptoms that patients have simultaneously to that one spot where you put the Botox in. That obviously has no effect. And of course, the Botox has to be repeated every 3 months, to the level that some patients report to me that they spend thousands, one patient, $200,000. $200,000 over 10 years on Botox. And 10 years later, she's sitting in my office before a consultation for the same symptoms she started out with 10 years prior. This has got to stop. That's my point. This is just really has to stop. I want my colleagues to take their fingers out of their ears and quit prescribing night guards, because a night guard protects the teeth but doesn't do anything for temporomandibular joint. You have to have some dental knowledge to provide this service. So, if this was a service that physicians could provide, or an ENT could provide, which they can't, they have to have a little bit of dental knowledge to provide that service. But the problem is, the dentists know, their perception is that there isn't any solution to TMD. And that's why 50% of dentists don't want anything to do with the problem, although they see the patients. And if they have a patient who makes their own diagnosis and says, I think I have TMD, they punt the patient to an oral and maxillofacial surgeon, who most often nowadays does not want to see that patient and does not even want to do surgery, because most surgeons have come to the same conclusion that I have come to. Surgery is not the answer for temporomandibular joint disorder. On the other hand, even the worst cases, the seriously damaged temporomandibular joint cases, can be treated with this little device successfully, because it's not about reconstructing the joint with a artificial joint, a total joint replacement. Not necessary, because if you make the inflammation go away, no matter what the joint looks like, no matter how much damage the joint is on X-ray, when you unload a joint, the inflammation goes away. That's why you treat tennis elbow with a sling. That's why you can treat any kind of pain of the knee with crutches. And you can treat TMD successfully with a protocol and a device that unloads the joint. Protocol is very important. It isn't just the widget. It's not just the device. You have to have a device that someone can speak with, they can breathe with, they can talk with. You can drink liquids with it. You just can't chew with it. So you got to take it out of your mouth when you go to chew. But the protocol is very precise and not too long. And if you'll do that protocol, you will get the effect. So both of the patients that I mentioned agreed for treatment. And I can tell you, I will be happy to report back in a couple months. Won't even take that long. Usually patients within the first 3 weeks report a significant decrease in painful symptoms. Painful symptoms start coming down pretty fast, usually within the first week or two. Patients report significant decrease in painful symptoms, the non-painful symptoms of ringing, tinnitus, proper name tinnitus, subjective hearing loss, the fullness in the ears, and vertigo, dizziness. Those three symptoms, which the ENT doctors have no solution for, but are part of the TMD conundrum, we know. And those symptoms do go down, but they're slower. It takes usually a couple months, a month or two, for the fullness, subjective hearing loss, and vertigo. Tinnitus, ringing, by my observation and long history, will sometimes take a long time. If tinnitus is really important to you, be patient with the tinnitus. It can take 6 months, 8 months, or even longer. Although I've had more than one patient that actually don't even give up after a year, and they've come back and contacted me after a year and said, it finally went away. My ringing went away. And the ENT doctors don't have a solution for Meniere's disease, which is ringing, fullness, and dizziness. Yet they they don't have the knowledge and the experience to treat Meniere's disease with a simple device that makes the inflammation in the joint go away. Well, it's been about 30 minutes since I started the live stream, and I do not see any viewers who has asked any questions. So we're going to wrap it up for today. Again, I encourage anyone who would like more information to go to our website, which is www.urbanek, U-R-B-A-N-E-K, urbanektmj.com. We already talked about the YouTube podcast, which is also for the dentist watching. You can see it on Dental Town. 249 episodes up to this time. And I also do a written blog once a week, which is published in different places. It's published to all of our 900 referral sources out of Middle Tennessee. We have 900 doctors, dentists and physicians, ENT doctors, neurologists, convenient care clinic nurse practitioners, and physician's assistants who send us TMD patients, 900 referral sources, and we also publish it on our website, urbanektmj.com. With that being said, I invite you to attend next Saturday's live stream, which I will produce at noon, beginning at noon, and encourage anyone who has any questions or would like to query me on any topic having to do with TMD. I am happy to respond. Until then, I'm Tony Urbanek, and this is TMD Demystified.